in the spirit of reconciliation, we'd like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past, present and emerging, and also extend that respect to all Aboriginal and Torres Strait Islander peoples here today. I am pleased to introduce our speaker, Hayley Ryan from Wound Rescue. With over 20 years of nursing experience and a passion for wound care, Hayley is a leader in this field and is also the former chair of Wounds Australia. At Team Medical, we're dedicated to supporting you with quality education, and we'd like to thank Hartman for making this webinar possible. We have Danielle from Hartman joining us today. After Hayley's presentation, we'll briefly explore some of Hartman's wound care products before diving into a brief Q&A session. Just a few quick housekeeping items. Cameras and mics are turned off, but we encourage participation via the chat. Please open the chat now and say hi along with where you're from, just so we get an idea where you're joining us from today. This webinar is being recorded and a link will be shared with you via email tomorrow, and we will also make it available on the Team Medical events webpage. As mentioned, after the presentation, we'll have a Q&A, so feel free to chuck your questions into the chat. We'll gather them together and then Hayley and Danielle will answer them at the end. We also ask that at the end you complete a short survey before heading off for the rest of your day. I'll now pass you over to Hayley.
Thanks so much, Caitlin and Team Medical, as well as Hartman, to inviting me along today to meet with all of you. I can see some familiar names, so wonderful to have you all on board, and I can see some other experts in the room, which is also great. Today, I want to talk about from assessment to application, navigating the world of wound care dressings. You know, the first thing often we ask each other is, you know, we've got this wound, what do we do? And the first inkling is, well, let's put a dressing on it. I'm hoping today, by the end of the session, we can flip that thinking to be a bit more about that holistic assessment. Next slide, please. Just a very quick disclaimer here for you. The photos that you will see today, I do have permission to share. Are you able to go to the next screen, Caitlin? And the next one.
There we go. Caught up.
Thank
Sorry,
you.
guys.
Thanks. So in terms of the learning outcomes, I do want to talk through how we appropriately assess and diagnose our wounds. How do we think about diagnostic testing? And yes, it's going to be a little bit different to what you can do in an acute setting as in comparison to that community setting. And I'm going to try and cover both. How you can manage infections, we'll just touch on that. And then we're going to really delve into how we start to unpack that dressing selection. As always, I like to be a little bit interactive no matter where you are. I'm hoping that you'll be able to join in. Next slide, please. So the first thing that I want to mention is, why is it so important that we monitor wounds? Just hit that down button again. One of the reasons is because wounds and the skin, they certainly change over time. I absolutely love this photo. I've got it from years ago. I got it from somebody else. I can't recall who, but you can see how the skin can present very differently over time. And it's so important that we do continue to monitor not only the wound, but the surrounding skin. Next slide, please. In terms of the principles of wound management, here's the basics. We do need to identify the cause of the wound. It is so crucial. Was it from, you know, being in the water at the beach where there's lots of bacteria and other bad things in that water? Is it that it was a skin tear from a fall? So we have other issues such as mobility that can hinder that person. What's the holistic health assessment? And then we delve into that wound assessment. We always want to adjust the care regime to meet the response. And what we mean by that is we try to stick to the same product range for at least 2 weeks, unless, of course, that wound's deteriorating. We do need to give it time to adapt to that environment and the product that you're applying. What's the overall goal of care? Are we looking at potentially a conservative management, a palliative management? Is it that the patient just wants to get back down to the shops and therefore doesn't want the exudate coming through that dressing? What's the overall goal of care? And then the other final principle of wound management is infection control, understanding the signs and how to avoid it at all costs, or if you do have an infection, how you treat it. Next slide. As always, the key elements to heal any wound, and just keep hitting that tap, thank you, is good amount of water, good nutrition, in particular high protein, and oxygen. These are the three elements that will keep every wound healing. But I always say, think about your patient cohort right now. How many of them eat a very nutritious, balanced meal every meal, 7 days a week? How many of your patients like to drink water? And how many have some form of oxygen depletion? Well, without these elements, we can delay that wound from healing to its full capacity. Next slide. There are lots of mnemonics that you can use to remember how to review a wound. And those that have come to my sessions before know that my preference, and it's purely a preference because I've used it forever and a day, is the HIDE mnemonic. And HIDE stands for history, examination, investigation, diagnosis, and an implementation. Simply put, HIDE is a way to remember how you can holistically assess not only the wound, but the person to get the best outcome for their wound care. Next slide. We'll go through this a little bit now. So when it comes to history, some elements that you need to consider: what family history do they have? What past history, both surgical and medical? If you think about it, if a patient has diabetes, we know that that puts them at a higher risk of potential diabetic ulcers, which can look down the path of amputations if not prevented. We want to consider medications. What medications will hinder a wound? Things like steroids, anticoagulants. You need to consider and review their medications. Their health behaviours. Is there any point in me putting on a patient very strong 40 millimetres of mercury compression on a 90-year-old lady who's not going to tolerate it and take it off as soon as I walk out the door? So what's an alternative? How can I start with a lower level compression and work the way up so that the patient becomes, relatively okay to continue with the plan? Is pain a factor? What's the overall quality of life for that patient? Their psychosocial history, and as I've just said, the main element to heal every wound, what is their nutritional status? So think about your patients now. When you're looking at their wound, how many of you actually ask the patient, how are you eating? How many meals a day do you have? What kind of meals? Is there high protein? Is there other elements that will help heal that wound? And under wound history, if we go to the next slide, we can also consider how long have they had the wound. That's really going to tell us a lot. Are we looking at an acute wound, perhaps a dehisced post-surgical wound, or are we looking at what we used to call chronic wounds, we now call hard to heal, where it could be, 4-6 weeks in the making, or sometimes longer. I have had patients who've had their wounds for 42 years. Patients that have had particularly venous lower leg ulcers for 16, 19, 25 years. These are far too long and have certainly stagnated. What previous wounds have they had? What previous treatment? If they have had ulcers before, how long has it been since they've had a free time from any ulceration? The reason we ask this is because we know that if somebody is suffering from venous insufficiency and we have closed that previous venous ulcer but failed to put them into compression stockings for life, they will have about an 80% return rate of any ulcer. So it's really important. And of course, allergies. What allergies do they have? Do they have allergies to iodine? Do they have allergies to certain adhesives? These are things we need to look at. Next slide. After you've looked at the H in HIDE, you can move to the E for examination and start with their skin, head to toe, a quick scan of your eyes. Do they have dry skin? Do they have cool temperature of their skin? Is their body mass, are they very, very skinny and quite macerated? Or on the flip side, are they rather large, which makes their body mass really hard to treat in between folds and things like that? What's their vascular assessment like? Have you checked every patient with a lower leg wound? Have you checked their pulses? Pedal pulse, medial malleolus, popliteal, perhaps into the groin. You want to track, are you seeing any potential decline in blood flow and mobility? Next slide. Also under examination, after you've looked at their history and their medications and their allergies, you've scanned them head to toe. Now you can examine the wound itself. And at this stage, you're getting a feel of what type of wound you think it might be. You need to consider, do they have pain or odor? And what's your overall goal of care? Next slide. And now it's time for you to think, I believe I know what diagnosis it is, but perhaps you might just need some more diagnostic tests, perhaps blood tests, x-rays, or other types of scans. Next slide. And once you're confident, you can make that diagnosis. In other words, what stage of pressure injury is it? What ulcer do you believe it is? And majority of us are still using the STAR classification scale for skin tear. So what type of classification system, skin tear is it? And perhaps you're using ISTAT for skin tears, and that's perfectly okay. Just use some classification. And now we also have the classification, the Globiad for IAD. Next slide. The final part of Heidi is that the implementation phase. You now know what it is, what you're dealing with, you have a very good history, and now you can move on to implement the plan. Next slide. So that is Heidi in a nutshell. And I always say, if this is the first time you're seeing Heidi today, don't feel overwhelmed. With anything you use as a clinician, the more you practice it, the easier it becomes. What I thought I would have a quick look at today as well is diagnostic tests. So next slide. Because when you're thinking about what diagnosis you believe it is, perhaps doing some other tests will help you get to that true diagnosis. Next slide. So there are certain blood tests, and of course, I completely understand those in the acute sector. It's much easier potentially to get some of these tests. In a home care environment, it may be a bit more challenging, but lean on your GPs and talk to them with a collaborative approach and see if any of these are relevant. For example, red blood cell count, hemoglobin, and hematocrit. This will show abnormally low, can show that the person has anemia, and that's a problem because we know that anemia affects the ability to carry that oxygen-rich hemoglobin, which in effect will slow that healing process. White blood cell count, we know, can lead to potential indications for infection. Platelet count is important because that could be a problem for stopping bleeding. Serum albumin, now the research here is hit and miss as to what it supports, but albumin prevents fluid from leaking out of the actual vessels. And when it is low, patients may experience edema and those weeping tissues, sometimes called leaky legs. Can also determine if the diet has sufficient amounts of protein. So if you feel that you've got a patient who eats really, really well and you've got all the best treatment plan in place and they're still not actually healing, perhaps look at serum albumin and see if you actually need to up that protein level. Of course, if we have a diabetic patient, we want to have a look at their HbA1cs and track that, as well as BGLs to make sure that they're stable. A wound culture. Now, this is another interesting one. 20 odd years ago, we used to do a wound swab on every single patient that had a wound. We now know we're in the world of overuse of antibiotics, and we really want to practice antimicrobial stewardship. So be cautious if you are going to take a wound culture, not suggesting you shouldn't, but think about, is it a systemic infection, or could you treat that wound topically with, say, a silver dressing or another antimicrobial dressing? Next slide. Couple of other tests that we would suggest is x-rays, particularly if you believe that somebody may have osteomyelitis, which is that bone infection. Really important to get that checked, particularly if they're a diabetic. And of course, you know, Dopplers, ABPIs, although we are leaning more to TPIs, toe pressure index now. I carry a case that can actually do both ankle brachial pressure index and toe pressure index, because, you know, a lot of the patients I'll see might be diabetic and they may not have that toe. So having both is the way that I find in practice is the way to go, but we also know that the research is leaning more towards TPIs at this stage. Next slide, please. The other thing to think about outside of those diagnostic tests is, what do you carry in your kit? And what I'm referring to here is, how are you measuring your wounds? Because that is crucial. Over the years, we've had a heavy reliance on photos, but where we actually see if a wound is really showing good signs of healing or deteriorating is through really good measurement. Next slide. And just a very, very quick rundown, and if you hit next again for me, we know that when we measure a wound, the greatest length of that wound is head to toe. So where the patient's head is to their toes, that's the length, and perpendicular to that length is the greatest width. Next slide. But another important element to measure is that undermining. And so how we do that is we use a clock face. As you can see here, an example where we've actually, we've got the cotton tips inside that wound, which shows the undermining. And the example that you can see here in that clock is a wound, and you can see the undermining area. And how you actually document it after you've put that swab into the area and moved it around to see how far it goes, you can then document it. Just click the next for me again, please, Caitlin. And again, that's the undermining area, which tells me from 4 o'clock to 6 o'clock, I've got an undermined area. So to document this, I would see how far it's gone in. And in this example, it's gone in by 2 centimeters. So my documentation will say undermining by 2 centimeters from 4 o'clock to 6 o'clock. And that's really important to get the size of the undermining, because it will tell you the next time round when you come and do that approach again, if you're on track to healing, because hopefully it's smaller. Next slide, please. Now, according to the literature, a percentage change of more than 30% over 4 weeks is considered a good predictor of healing. And that is why we say it's so important to get the measurements right. Now, I want to ask you all a question, and I'll get you to drop it in the chat right now. Drop it in the chat.
Sorry, Hayley, you might have cut out briefly there.
Wounds, amazing. Oh, it cut out. So what I'm asking the audience to do is to drop in the chat, what are the main types of wounds that you see in your day-to-day practice?
That's better.
Excellent. You can hear me okay? There we go. Skin tears, chronic ulcers, surgical wounds. Okay, perfect. Neuropathic, diabetic. You're saying exactly what I thought you would say. So go to the next slide, please. And here's what the literature tells us. No matter where you are in the world, the main types of wounds that you're likely to see is that incontinence-associated dermatitis, skin tears, all of the ulcers, which you're saying, arterial, venous, diabetic, pressure injuries, and burns. So go to the next slide. The next question I have for you all, what do you think are the barriers to managing these wounds? What's actually hindering you from getting to healing? Drop it here. Knowledge, yeah, okay. Compliance, yep. Nutrition, yep. Lots of compliance. Lack of knowledge, good nutrition. Frequency of seeing the patient, absolutely, particularly if you are a home and community practitioner. Cost, I knew that one would come up, absolutely. Circulation, so perhaps other etiologies. You guys are spot on. Perhaps someone's living with dementia. These are all the things that I would expect for you to say. Go to the next slide. And you've hit the nail on the head, but one of the other reasons a wound may not heal in the normal trajectory of time is in fact wound infections. Next slide. And just simplistically said, there are several signs of infections, such as expanding redness around the wound, yellow or greenish coloured exudate, red spreading outside by about 10 centimetres, increased swelling, tenderness or pain, and at times, dependent on whether it's a local infection or systemic, you may also have a fever. So one of the things, and we won't have time to go through this today, but I would encourage you to have a look at some of the guidelines that are available free that really talk about, is it a local infection where you might be able to treat that wound with antimicrobial dressings, or are you in fact looking at a systemic infection where there is a place for that oral antibiotic or perhaps even IV antibiotics? Okay, next slide, please. What I'd like to talk through now is a bit of an in-depth approach to looking at dressings. And the reason I spent the first part of this talk going through assessment and diagnosis is because if we don't get that foundational part right, the dressings won't work no matter how much you spend on them or how little you spend on them. You've got to get that holistic approach right first. Next slide. This document, you can actually just Google it. It is free of charge online. I have not had a part in developing this, but it's been around for years. I think it's a great freebie that you can all get your hands on. And it really does just talk through wound dressings and unpacking them. Now, I can tell you that the team and QUT University are in fact updating this. So I'm looking forward to the next update. Next slide, please. Now, when it comes to dressings, you need to consider what's actually the reason you put a dressing on. Well, here's some of the reasons. It's to provide rapid and cosmetically acceptable healing. Any plastic surgeon will tell you the process and aim for them is to decrease scarring and to give your skin the look that it had as close as possible to how it was before it got wounded. It's to contain odor, to prevent pain, potentially treat infection, reduce that exudate, and to cause minimal distress or disturbance to the person. So if you're still applying dressings that's hurting the person, you need to think about, is it the right product for them? And just like medications, before you apply any dressing, you need to consider, what's the action of the dressing? When should it be used? Are there any contraindications? Do you know the correct method to put it on? And do you have sufficient knowledge about that product? Next slide. And of course, you mentioned some of these factors that will affect wound healing is the cost effectiveness. What about client concerns for actually wanting to use that product? The person's medical capability, the person's understanding of the dressing. Maybe it was coming from a pharmacist. Did they know how the product worked? We now know that around 70% of customers going into a pharmacy, according to the Pharmacy Guild of Australia, are in fact asking questions about wound care products. Are there any health behaviours? Is it a climate issue? What I might put on here in New South Wales may not be as effective for, say, someone in Queensland in summer. Next slide. So, what are the things you need to think about when you're gathering your product line? Obviously, a cleansing agent. Now, yes, you could use normal saline, There are other products on the market now, whether it be microdacin, granudacin, Prontosan. There's a whole list of them. I'm not here to endorse any product, but find the one that works for you. A primary dressing, you may need a secondary dressing, and you may need a retention dressing. Next slide. But whatever you do, I would encourage you to remember that dressings are 10% of good wound care. Everything else we've discussed in this short webinar today is the most important factor. But let's get into the 10%. One of the things I try to teach on when I'm talking about dressings is to think of dressing products just like medications. When you had to learn medications, you had to learn the generic first before you could learn the brand. For example, paracetamol. Once I say paracetamol and asked you for the brand, you would say Panamax, Panadol, Febridol, and the list goes on. It's an easier way to remember the actual product. So on the same lines, I encourage you to learn all of the generics of every dressing product, and they're here on the screen right now. This is going to help you understand the product brands that come with it, because the good thing is that there's over 4,000 products on the Australian market today, coming up closer to 5,000. So there's a lot to remember, and it's no wonder clinicians get confused with what product to apply. So here are some of the generics. So for example, one of the generics is foams. So think about what foams you have in your cupboard right now and what brand. Can you give me some examples here in the chat? What are some foams that you have in your cupboard by brand? Alleven. There we go. Thank you, Chantel. Yep, everyone's got Alleven. Mepilex. Excellent, excellent. So you can see there are a number. What about hydrogels? Hydrogel's another generic. Do you have any hydrogel brands within your cupboard? Yeah, yep, you might have, yeah, Solasite. I knew where you were going there. Solasite, perfect, perfect. So you can see where we're going. Okay, next slide. What I'd like to do now is, we're not going to go through all of them for time, but I'm going to take you through some of them to help you unpack the detail for each of these generics. And we're going to start now with alginates. Alginates are generally made from seaweed. Their whole premise is to absorb fluid and turn it to a gel. In other words, they're highly absorbent and have those hemostatic properties. They come in different types, whether it be ropes or sheets. You can generally cut them, but you wouldn't use alginates on minimal exudating wounds, and particularly dry wounds, or on the flip side, really heavy bleeding wounds, because it's just not going to have that capacity to absorb them. You've got some general examples on the screen. So they're your alginates. Next, let's move to the next one. The next one is your gelling cellulose fibers. Now, they're composed of 100% carboxy methacellulose. They come in packing ribbons and sheets, but these are for highly exudating wounds and have claims to say that they can support infected wounds. Again, you wouldn't use them on dry wounds. You do, for all your packing products, leave a tail outside of the wound so it's easier to grab next time. Next slide, please. Some of you already identified, you know what foams are. They are hydrophilic. They do add a bit of padding as well. Sometimes we're using them now as prophylactic dressings, particularly in the ICU or perhaps the ED department. You've got some examples on the screen as well. And you wouldn't use foam dressings on dry wounds. Next one. Hydrogels is the next product that we want to go through, and some of you said Solasite. We've also got the Hydrosorb gel from Hartmann there. They're basically high water content, and they contain those insoluble polymers. In other words, they can provide some autolytic debridement, which is why some of you will go, you know what, I've got this really thick, tenacious exudate. It doesn't matter what I do, I can't get it off, and perhaps a Solasite might work. They can come in a tube. You can put them on any kind of, your forceps, squirt them on and put them in, or even some other products, even some gauze to put them in the wound. They can now come in hydrogel sheets. They're used on minimum to moderate exudating wounds. They're actually really good on burns. In fact, I keep some in my first aid kit at home as well. Next slide, please. We then move down to your high absorbent dressings. Most of you know the Zetravet range. They're made from materials with an inner absorbent core. They do have those hydrophilic properties. Great as a secondary product as well, so they'll capture anything that your primary dressing can't hold. Next product. The next one is your paraffin dressings. Now, these are an open mesh cotton rayon viscous gauze. They're impregnated with paraffin. Some are impregnated with medicated antiseptics as well. They come in sheets, and they're okay for low to moderately exudating wounds. One little tip that I'll provide here is things like Gelinet. I tend to find because of the wounds I deal with are highly exudating. Putting on a paraffin dressing can sometimes cause more problems in terms of maceration because there's too much fluid there. So weigh it up. If you have too much fluid, perhaps a paraffin dressing isn't the right approach. Next slide. There are silicone dressings, and can I say in the past 8 years, this is the way of the future. Silicone dressings are really great on very frail skin. So for your elderly patients, these are perfect. They go on without causing trauma. They come off without causing trauma. Skin tears, they're perfect on, and we've gone away from the old-fashioned Steri-Strips. Next slide. The next one here is your cadexamer iodine. So they're made from the micro beads that contain 0.9% iodine. These products are a slow release, so you're not going to get that big whack of iodine, which is why you can leave these products, the cadexamer iodine products, on for a few days. They do come in a paste, a powder, and a sheet. Some of you might be questioning, where would I ever use the powder? Can I say sometimes your neoplastic wounds or your cancer wounds, they're often in very difficult places on the body, and they're hard to get a dressing on. And that's where sometimes I might use a powder, for example. Next product, silver dressings. I'm sure you know these well. They're a broad spectrum antimicrobial agent. They can be potent against MRSA, Pseudomonas VRE. Of course, all of the products with silver in them will have varying abilities to do this. They also have anti-inflammatory properties. So another great product, and when we spoke earlier about infections, whether it's systemic or topical, local, perhaps these are the products for choice when they're not a systemic infected wound. Next slide. Medical grade honey, one that is very much underused, but it's been around for thousands of years. Now, I do have the Capilano down the bottom with a big cross. When we talk about medical grade honey, it's exactly as the name suggests. It's not the locally bought down at Coles or Woolworths honey. It does need to be that medical grade. It's got the 82% carbohydrates, enzymes, and amino acids. And those things there are some of the reasons why when you put a medical grade honey on a patient, they can sometimes say, oh, it's stinging a little bit. That's normal. If that little bit stays around and doesn't go away, then you might consider they might be sensitive to the product. Also comes in gels and sheets, great for infections, great for odor. But again, weigh it up. It's a wet product. Do you have a risk of maceration? Is that the right product? Next product. These are the products that I call the washing machine of the dressing products. Why? Because their technology is really to clean the wound, to rinse the wound, to debride the wound. Things like, for example, your hypertonic saline or Ringer's solution. Very much, in my opinion, underutilized. But if you've got products that wounds that just won't budge with that very thick, tenacious slough, give it a washing machine, give it a HydroClean, for example, for a good week or two and see if it desloughs and gets rid of that muck for you. And the final one that I wanted to show you were these odor absorbing products. They contain activated charcoal, which is said to absorb odor, bacteria, and exudate. You can use them on all different types of wounds that are highly colonized, such as malignant, fungating cancers, and have that offensive odor. What I will say with these products, they're often very expensive, and I don't find they help as much as I would have liked for the wounds I've used them on. But again, the wounds I'm seeing are often at that end stage. So weigh it up. Is it going to be appropriate for your patient? Next slide. So that's our dressings in a nutshell in a very short period of time. And people will always, clinicians often ask, well, when should I change the product? Well, many, many, many years ago, we spoke about the 75% strike-through rate. So when you're seeing these dressings, as you can see on the screen, and there's only a small amount of strike-through coming through that dressing, perhaps you don't need to change it, but you want to wait till it gets more to the edges. But can I say that products have certainly evolved over the years, which is why we're now seeing dressings that can stay in place for 5 days, 7 days. Your things like some of your silicone products up to 14 days. So look at the manufacturer's recommendation and how much exudate is coming through that dressing. If it's not holding and you're still having to change your dressing every day to 2 days, you've got to reevaluate, is it the right product for that amount of fluid that's coming out of that wound? Next slide, please. And particularly for patients that are living at home, and perhaps you're getting some home care services where you're a clinician that only goes in maybe once a week or once every 3 days, it's really hard to continually check the integrity of that product. So getting other products around the dressing to make sure that the integrity stays, particularly if the person is having to have a shower. What we know is the moment that wound, that dressing gets wet and stays on, it is going to harvest that bacteria. It is then has the potential to break down. So spending a bit of time to educate patients on protecting the integrity of the dressings is really important. The next slide, we talk about taking that 2-week challenge. Any woundie online will forever say to you all, stop mucking around with the product type and keep the same product type going for at least 2 weeks before you alter, unless, of course, you've made a clinical judgment that it's not appropriate. Okay, the last thing I want to bring to light for you all is a couple of case studies. Now, often I will give you a case study and show you a success. I want to flip the narrative today. If we go to the next slide. And I would like you to think about, have you diagnosed that wound well? Have you certainly included pain as a potential assessment? And then choose a dressing wisely. What we're going to do now is I'm going to show you only a couple of wounds. And what we're going to do is you're going to tell me what you might apply to this wound and, more importantly, why. So if we go to the first wound photo, you can see a lower leg ulcer here. Next slide, Caitlin. Thank you. And it's no surprise, you can see a lot of maceration. So based on that, you can tell there's lots of fluid. What are you going to apply on this wound for what you have in your dressing supplies? What might you put on this dressing? Have a go. Mepilex or Aquacel foam. Okay, Aquacel foam, Mepilex AG. Alginate dressing. I like it. Alginate, good, good. Durafiber, sure. Okay, we're seeing a lot of alginates. Great, great. Those that are saying silicon, I would probably caution that because the silicon will not have enough properties to soak the fluid up. But those that are saying things like alginate or perhaps a gelling fiber, they are certainly going to soak up the fluid. I like it. Somebody said an alginate, then a Zetravet plus. Brilliant. You're going to make sure your secondary is going to capture it. I like it. Now, what if I was to tell you this patient had a confirmed venous ulcer? How would you fix those products in place? What would you use? Compression. Well done. Well done. Absolutely compression. If we have a known venous ulcer, we do need to provide a compression bandaging. So to recap on this wound, you might consider an alginate or a gelling fiber because both those two generics are going to soak up the fluid. You might put a Zetravet on top. So if anything comes through, the Zetravet as the secondary dressing will capture it. And you've all said compression bandaging. Love it. Well done. Let's go to the next one. Okay, we've got a necrotic and ischemic lower leg wound. What will we apply here? Something to debride, some people are saying. Surgical review. Michelle, I like where you're heading. Give me some more details. That's great. A debridement product, a solicite gel. Okay. Gel and foam, hydrogel. Okay, great responses, but here's what I'd say, and I really like where you were going, Michelle. You would absolutely get a vascular assessment. Perhaps if this was a patient in an aged care home, you might look at the Advanced Care Directive and see where the patient wants to go. Is it conservative? Is it palliative? Or let's send them off for further investigation. We wouldn't actually put a hydrogel on this type of wound. In fact, at this stage, we want to keep it dry. If we moisten this type of wound, which is necrotic and ischemic, we run the risk of turning it gangrene. So, Michelle, you're on the money. We're going to send this patient off for urgent treatment should the Advanced Care Directive suggest that that's the approach. Nice job. And then the next wound. Okay, we've now got a cancerous wound, an SCC. It's got high amounts of exudate. It's got really bad odor. What are we going to apply here? Surgical intervention, infected. Okay, AG, Inodine. Okay. So Alexia's thinking Inodine for the SCC. No problems with that. Iodosorb powder. A silver dressing, spot on the money, everyone. Maybe a charcoal over the top for the odor. Absolutely right. Now, the SCC, you've got to determine, are they going to have surgical intervention? If they're not having surgical intervention, then we just want to manage the symptoms of pain, odor, and exudate. And that is where things like your charcoal dressing absolutely might come in place, your silver product, or potentially your cadexamet iodines. All right, the final wound for you to have a look at today is this one. This is a lower leg venous ulcer. What are we going to do for this wound? What do we think will apply here? Think about what you're looking at. Think about, okay, so someone's saying solid gel, you want to really pull up that tenacious slough. I agree. Compression to secure for sure. Debride. I like it, Jenny. Absolutely. Great. Debridement, iodosorb, foam, compression, tick, tick, tick. These are all great answers. Okay. Can I tell you on this one, I did debride using a curette. We cleaned it all up. If we go to the next slide, this is 1 month later. So you can see that we've de-sloughed, we got rid of that purulent exudate. It's not exudating as much. It was copious amounts of exudate. Now it's only minimal amounts. What are you going to put on this wound now to keep it healing? Moisture, okay. What would you put on it to moisture? Put a silicone, a foam dressing, Flaminol Fort. I'm seeing lots of things come through. Solugel foam dressing. Okay, okay. We had moderate amounts of exudate still coming through. So what we still used at this stage was a gelling fibre dressing followed by Zetravet and continued the compression. Let's go to the next slide. This is 4 months later. So we're definitely on the home run here, but now the wound is dry, scaly, but it is on track to healing. What would you suggest now? Because we've been using the gelling fibre, but that was soaking up the fluid, no problems. Now we don't have any fluid. A moisturizer, okay, it's still a bit open, so we probably wouldn't want to put the moisturizer or emollient on the open area. Absolutely. Alana, we want to look at the nutritional status. Okay, just be mindful your jelly nets, your Gelinet, your Bactigra, you don't want to continue to macerate this too much. Can I tell you guys, at this stage, we just put a foam dressing on. There was small amounts of fluid. We put a foam on. We continued to use the compression, and that wound did heal. Okay, next slide. Well done with all your answers, everyone. So one thing that I want to highlight is referring early. So reach out to your GPs, talk to your wound specialists, get to know who they are in your area. Think about the Peak Body Wounds Australia. They have their conference next week. I'm hoping to see some of you there. But remember, when in doubt, get it checked out. Next slide. So my take-home messages to you all today, and you've all done a wonderful job, is to always actively involve the patient in wound care. Chronic wounds are a silent epidemic, so please refer early, assess and diagnose correctly. And here's my biggest tip. Think about the skin because prevention is definitely key. If you do want to stay in touch with me, please take a scan of the QR code, which is next on your screen. And with that, I thank you all so much. Caitlin, can you go to the next screen? And I will hand back to the fabulous Team Medical and Hartman team. Thanks, everyone.
Thanks, Hayley. We'll now hear from Danielle. Thank you, everyone. I'm a bit over time, and we had a few tech issues there. So if you can stick with us, we greatly appreciate it.
Thank you, Hayley. That was wonderful. I always learn something new with your presentations. Before I discuss the features and benefits of Zejibit plus silicone border, I want to acknowledge at Hartman, we understand wounds are challenging. So when you look at a wound, there are just so many facets that need to be considered outside of the wound itself. Fundamentally, aiming for wound balance constitutes a shift in focus from managing wounds to leveraging clinical intervention of healing wounds wherever possible and as early as possible. The patient and clinician are on this journey together with the patient's quality of life, needs and preferences, as well as expected clinical outcomes at the centre of the decision-making process. Patient engagement is crucial both to achieve outcomes and to improve patient experience. So with that in mind, I'd like to introduce you to the wonderful Zejibit plus silicone border. Next slide, please. So Zejibit plus silicone border is a sterile, single-use absorbent dressing with a silicone interface for the treatment of acute and chronic wounds. It's available in a range of shapes and sizes to suit different wound types. Zejibit plus silicone border provides that protection inside and out. Thank you. Next slide. I'm just going to show you a short video of the mode of action. We got some sound.
Sorry, the sound doesn't appear to be working there, but we'll share it with everyone after so they can watch it.
Okay, no worries. I can walk through it. So what you can see here is you can see that the exudate is actually going up into the core of the dressing, and those superabsorbent polymers are actually holding on to those MMPs and fluid. And once it reaches saturation point, it doesn't actually leak out. So this is also a great dressing to use under compression and for retention. It's also taking up that odor and trapping it in that core of that dressing. So the nice thing about this is that you also don't get maceration due to the exudate leaking out. You can see all those MMPs being trapped in that core of that dressing. It's got that anti-strike through layer. It's also waterproof, which means that the patient can shower and have that good quality of life. It's nice and conformable, so it shapes really well to the body. It's highly breathable as well. And bacteria proof. It prevents bacteria from getting into the wound. You can also lift and reposition the wound if need be. Thank you. Next slide. So what are some of the benefits of Zejibit plus silicone border? Well, it really balances the microclimate to create the ideal environment for that wound to heal. It reduces those inhibitors, which was just evident in that video, to promote wound healing and also protect the wound. So you've got that waterproof layer, which prevents bacteria from entering the wound. Next slide. So Zejibit plus silicone border reduces the risk of leakage, strike through and odour, can stay in place for up to 7 days and is shower proof. Very comfortable to wear and almost painless dressing changes due to that silicone interface. Next slide. So in summary, Zejibit plus silicone border is versatile, effective and patient friendly. Next slide. And to top it all off, it comes in a range of different sizes and shapes. So we have Zejibit plus silicone border in all these wonderful shapes, because we know that wounds aren't perfectly round. And that's the bordered version. And then we also have Zejibit plus silicone, which is the non-bordered version. And these are all available from Team Medical. Thank you so much. And back over to you, Caitlin. Thank you.
Thank you, Danielle, and thank you, Hayley. Hayley, we just have one quick question that has come through. Can you please advise on the use of Chlorhex as a cleaning agent?
Yeah, look, it has its place. Thank you to whoever asked that question. The only thing I would say is think about your patient. Is that going to cause any pain or uncomfortable feeling when something as basic as maybe a microdacin or a granulodacin or a prontosan won't cause that same effect? So base it off your patient. I mean, we used to use chlorhexidine many, many years ago on every wound. We don't do it so much now, but I'm not saying you can't. It's just like, you know, a number of products we say don't use it. Everything has its place. I hope I've answered that question. Nothing's black and white in wound care. I think you're seeing that.
Yeah, absolutely. Thanks, Hayley. The other question we had was whether you could use silicone as a primary dressing followed by Zejibit, which I believe we have answered throughout the presentation that can well and truly do that. And then also there's Zejibit plus silicone border, which has all of those benefits in there.
Yep. Can I jump in, Caitlin? Helen has asked also about betadine, or in other words, iodine-based products. Again, yes, you can. You need to know your patient. You know, gone are the days, the latest guidelines for skin tears, for example, we do not use iodine-based products on skin tears. We know it actually dries the wound, dries the surrounding skin. It can actually hinder it from healing. But if I have a necrotic foot or like that ischemic patient that I showed you, absolutely I'm going to paint that with betadine and send them off for review, because my intention is to keep the wound dry. Whereas all other wounds that I'm aiming to heal, we want to keep them moist. That is the difference.
Great, thanks, Hayley. Everyone, there is a mini survey that we would like you to complete. We'll also send out this link via email. We'll share some details as well and how you can get in contact with Hayley, and also in the Z-Trip products and some other products that we have available. That email will be sent tomorrow, and this will also be available online. Thanks again for your patience. I know we've gone a bit over time, but it's been great to have this session. Yeah, thank you. Thank you for joining us, and thank you, Hayley, and thank you, Danielle.
Thank you. Thank you, everyone.
Our pleasure.